So I'm David Liang. It's a complicated question where I practice. Currently, I'm practicing at Hoag Hospital in Newport Beach. Previously, was at Stanford for about 25 years, and I will be moving my practice to USC beginning in August to help build a program over there. So Marfan syndrome is a genetic condition. It's caused by a mutation in a gene called FBN1, which codes for fibrillin. So fibrillin is elastic fiber in your body that guides the development of the body, and it's everywhere. So you see features everywhere. From an outward point of view, the most common thing people notice is that patients with Marfan syndrome tend to be very tall. In particular, they tend to have very long limbs, long fingers, long arms, long legs is the classic feature. But really, the reason why a cardiologist is involved, which is me, is that what causes most of the problems and the danger of Marfan syndrome is that it affects the aorta, which is the main pipe that comes from the heart out to the body. And that will become enlarged over time in about 90% of people with Marfan syndrome. And when it gets too big, then there's a risk for it to tear and rupture, which is obviously highly fatal. So that's why I'm involved. But the other aspects are also very important. It involves the eyes, and it can lead to retinal detachments, lens dislocations. And then there are also, the outward features, and what oftentimes draws people to medical attention first are some of the musculoskeletal features, like scoliosis and pectus. So pectus is an abnormality in the way the sternum develops. So it can either go inwards or outwards. But that gives you sort of a broad overview of the condition. So that's Marfan syndrome. And there are many conditions that are related to it. And so the foundation, as well as me, are involved in managing those conditions, which share some of the features with Marfan syndrome, like Loeys-Dietz syndrome, vascular EDS, and some of these other genetic conditions as well. We obviously can't make the gene go back to normal, okay? But I would say in the last 30 years, there's been huge progress, and a lot of that has been the results of cardiac surgery. The average life expectancy back in the 60s for men was about 35, women about 45. Our expectation is now that patients with Marfan syndrome hopefully will have a normal life expectancy or near normal life expectancy. So now it's not a drug that we can do. We have drugs that will slow down the progression of the aneurysm and such, but probably the biggest breakthrough has been through improvements in cardiac surgery, and where we can replace the aorta, the area at risk, and that really deals with the survival aspects of it, because the aortic was the probably cause of death. But you're right in the sense that, okay, are there other aspects of the disease that we can't treat yet? The answer is yes. Okay, and we obviously those things are supportive. And that's really where I think the future lies for us, is to really get at the underlying sort of instead of sort of bandaging around it, right, is really to treat the disease and treat how it is that this variant or mutation leads to disease. We're not quite there yet. Obviously that's where a lot of the research is heading, and trying to understand, okay, how do you get from, we know the gene that causes it, we know the mutations that cause it. Well, how does that then lead to actual disease, right? And because that's an important part, is understanding that process. Because once you understand that process, then you can begin to say, oh, okay, this is how I interrupt that. And so obviously huge progress in that regard. And I'm not quite there yet, but and it's hard to predict the future. But I'm sort of hoping that by the time I totally retire, which will probably be 10 years, 15 years from now, that there'll be a whole different paradigm. And instead of us sort of managing the disease and the complications, it's really about treating it. Patients come in different ways. Okay, obviously there's enough awareness now that if somebody has somebody with Marfan syndrome in the family, then through screening, a family member, children, parents, we will often pick up cases. Hopefully that's our ideal case, because we'll pick that up earlier, right, before something bad happens. Unfortunately, about a third of patients with Marfan syndrome are what we call spontaneous mutation, where they don't have any family members. They're the first patient in the family with it. And then for those patients and patients who aren't picked up through family screening, the first avenue of entry usually occurs in early childhood, and oftentimes it's the eyes. And so ophthalmologists will pick it up, and they'll notice that the parents will notice that their kid can't see very well, and then ophthalmologists will take a look and say, oh, the lenses are out of position. And that the ophthalmologists are well trained on that. That's a light bulb that goes off. Okay, Marfan syndrome. So that's one avenue early on. Sometimes it's just, kids tend to be a little floppy, long limbs, particularly in the more severe cases. An astute pediatrician will pick that up. Then there are a group of patients who are milder, where again, there's a second group, usually I would say in the teenage years, because that's when people have their growth spurt. And so many of these features that we look for in terms of the pectus abnormality, the scoliosis, become much more apparent. Okay. And then that will prompt, again, the pediatrician to say, or a parent. In fact, and surprisingly, that a lot of times the parent makes the diagnosis rather than the pediatrician. They'll say, it's not quite right. Something's wrong. And that will prompt an evaluation, hopefully. And then at that point, an echocardiogram is often a very important part of that, as well as a more formal eye exam. But there are also some patients that aren't diagnosed until, unfortunately, they have their dissection. And that would be in the 30s or 40s, and their outward features are there oftentimes, but not quite as prominent. And that's obviously not the way we want to make a diagnosis. We don't want to make the diagnosis when they come in on a helicopter. So that's one of the goals of the foundation, is to really sort of, get earlier screening, push hard to really diagnose the disease early. But there's always going to be some that are missed, unfortunately, just because there are some patients with Marfan syndrome where outwardly you can't tell, which is obviously makes it more challenging in that situation. So the foundation I refer to is the Marfan Foundation. Marfan Foundation, I think, has been around for like 35, 40 years ago, and it's grown tremendously. Started off with Reed Puris, one doctor and 5 women, and now it's grown to, I don't know, the membership is probably in excess of 30,000 people right now. That will be patients, families, healthcare workers. Primary goals are actually to support patients with Marfan syndrome from all different aspects, right? So one big goal is obviously to support and sort of promote research to really get at the cause and the cure, right, of Marfan syndrome. That's one aspect of it. The other aspect of it is to provide support for people who have it, information support. They have a hotline, that's manned by a nurse all the time, as well as multiple social media corridors for people to do it. And then the other aspect of also is to build community, because as you know from rare diseases, it's challenging, right? Because it's hard to find a doctor, and it's hard to find somebody else who has a shared experience. And no matter what you're going through, if you have somebody that you can share the experience with, it makes it easier. I don't know if the wording, misery loves company is true, but it probably is, right? And it's just that you don't feel as alone. And the foundation, I think, does a very good job of trying to promote that community. We have an annual meeting every year. This year will be in Atlanta. And typically we'll get we have 500 or 600 participants. It's a chance to really get together, bond together, especially for the kids. They finally get in the room. And when it's tough when you're a kid, right? You look different than everybody else. Suddenly you're in a room with a whole bunch of people that look like you, and that feels good, right? That always feels good. So that's good. And then there are walks across the nation. That program's grown hugely. So there are a lot of things built to building community, and it just it develops some degree of camaraderie to make dealing with the challenges easier. So yeah, I was at the gala. I don't always go. I think that's my 3rd gala I've been to. Galas are not my thing usually. But it was actually a lot of fun. It turned out. In some ways, to be truthful, I was a little dreading the whole thing, but it was fun because it was a great opportunity. A bunch of my patients were there, a bunch of colleagues were there. And so it felt like a great reunion. So all the people that that I've been working with, been caring for, and then which is also part of why I like Marfan syndrome so much as a practice. And I think some people will all find that, a lot of people in rare diseases will find that, because in many cases, unfortunately in medicine right now, there's a rotating door of doctors and physicians, right, because of insurance or whatever. But I mean, for me, it's been lucky because, my patients have been with me. I was just on the phone with one of my patients who I've been taking care of since she was 14. She's 40 now with 3 kids. And that's cool. And I get to be sort of like her grandpa, or pseudo grandpa, right? Which is, I think it's kind of fun. It's a wonderful feeling to see your patients, go through life and enjoy all the things that life can bring them. Challenges in rare diseases, but that's also really one of the hugest rewards of being associated and taking care of patients with rare diseases. Rare diseases are challenging, okay, and unfortunately they're underdiagnosed. And this is one of the challenges, is that we need to get much more awareness out there for people, because awareness of these rare diseases it turns out rare diseases aren't all that rare, right? As you probably know by now. And so I think we need, certainly for doctors, we need to say, just because we don't know what it is, don't assume that it's nothing. Hopefully somebody else out there knows what it is, and listen to the patients, because sometimes they'll tell you what's going on if you just open your ears and listen to them.